So an overview of how today is going to go. I'm going to start off with a background information session on opioid derivatives, including heroin, fentanyl, carfentanil, and medications used for the treatment of opioid addiction. And then we're going to have the opportunity to talk with Molly from the Rockbridge Area Health Center and Marcia from the Rockbridge Area Community Service Board. So before I get started, just a quick thank you to everybody who's been here for these community conversations. I really appreciate your time and your passion. And as we've talked about in each of these community conversations, addiction is a disease that, affects the makeup of our brains, and it deserves the same attention and care as any other illness. So you all being here are helping to take that first step in destigmatizing addiction, and I thank you all for that. So let's get started. All right, the opioid crisis. So for more details, check out the first and second community conversations on the opioid crisis on RAPC's YouTube page. The opioid crisis is a health crisis that affects the majority of Americans in some way. In 2019, around 10.1 million people aged 12 and older misused opioids in the past year, and almost 50,000 people died from opioid-involved overdoses. So there are four general categories of opioids tracked by the CDC, including natural opioids and semi-synthetic opioids like morphine, codeine, and oxycodone, methadone, which we're going to talk about later today, synthetic opioids like fentanyl, and heroin, which is an illegally made opioid created from morphine. The opioid crisis affects everyone, and it crosses age, gender, race, and socioeconomic lines, which make it such a significant health problem and part of the reason why I chose to address it in these conversations. So now I want to take a few minutes to understand how the opioid crisis has changed over time. So there are three general waves to the opioid crisis. The first wave is what we covered in the first community conversations. So this is when the prescription rates of opioids increased dramatically, leading to higher rates of addiction and overdoses in the 1990s. And as you can see in the graph here, the number of deaths due to prescription opioids start to slightly decline when the number of heroin deaths start to increase. Once doctors began to realize how addictive opioids were, they began to put more regulations on the prescriptions of opioids, which gave rise to more of the illegally made and sold heroin. This can be referred to as the second wave, which started around 2010, and this is characterized by that increase in heroin addiction and overdoses. So the third wave can be seen as starting around 2013 with increased deaths due to synthetic opioids. You can see on the graph that the mortality rate has increased extremely significantly, and we're going to talk about why this is later today. So check out our past community conversations to get a better understanding of the first wave of the opioid crisis, but we're going to start off here today by looking at heroin, which is what we saw in the second wave of the opioid crisis, starting around 2010. So heroin is an illegal opioid that's made from morphine. It has very similar effects to the other opioids that we talked about in our last two community conversations. Some short-term effects of heroin include a euphoric rush, dry mouth, itchy skin, a clouded mental state, as well as nausea and vomiting. Some of the longer-term effects include insomnia, heart problems, damaged tissues where the drug is administered, liver and kidney diseases, as well as mental disorders like depression and antisocial personality disorder. The main concern with heroin overdoses is similar to what we talked about in the last community conversation about breathing rate, so check that out for a more in-depth understanding. But heroin also slows down your breathing rate, and if you take too much, your breathing rate slows down too much, which causes that lack of oxygen to the brain, which can cause brain death like we talked about before. So the first and second wave are linked in that heroin began to act almost as a substitute for prescription opioids. In fact, 80% of people who use heroin first misused prescription opioids. And while they may be separated into those two different waves, they are linked and are still both important to address. So even while the heroin overdoses slightly decreased around 2016 with that rise in synthetic opioids, it's still a significant contributor to the opioid crisis. In 2019, around 28% of all opioid overdoses were attributed to heroin. So now let's talk about fentanyl and carfentanil. Fentanyl is a synthetic opioid, which means that it was created in a lab, but still has similar chemical structures and properties to natural opioids. It works as natural opioids do, binding to the opioid receptors in the brain that cause that huge release of dopamine that we talked about before. So, fentanyl causes some positive effects, such as extreme happiness and pain relief, but also has effects like drowsiness, nausea, confusion, sedation, and unconsciousness. We talked about the consequences of some of these symptoms again in our last conversation, especially that significantly slowed breathing rate. So it can be prescribed by a doctor for pain management, typically for extreme pain like advanced cancer. And when doctors prescribe it, it can come in the form of transdermal patches, tablets, lozenges, or nasal spray. And fentanyl is extremely powerful, being 50 to 100 times stronger than morphine. This means that a lower quantity of fentanyl can cause a much stronger reaction, making it a lot easier to overdose. Carfentanil is another synthetic opioid similar in structure to fentanyl. However, it's even more potent, being 100 times stronger than fentanyl and 1,000 times stronger than morphine. And in this image here, you can see how big of an effect carfentanil has as compared to morphine and heroin. So it's important to be aware of these potencies because of the way that fentanyl, go to the next slide, because of the way that fentanyl and carfentanil are being used outside of prescriptions. So, synthetic opioids like fentanyl are now one of the most common drugs involved in drug overdose deaths in the United States. In 2017, almost 60% of opioid related deaths involved fentanyl as compared to only 14% in 2010. So, the frequency of fentanyl use is increasing, which is problematic. Fentanyl is also being mixed with other drugs like heroin, cocaine, and methamphetamines without the consumer's knowledge. This is extremely dangerous because, as we saw, fentanyl is extremely potent and it only takes a small amount to induce an overdose. If you look at this picture here, it can show you how easy it is to overdose on fentanyl and carfentanil because it only takes that small little bit. Last week, Officer Ferguson shared his own experience with coming into contact with fentanyl and how the smallest amount can cause an overdose. So, officers on duty have to be extremely careful when entering those certain situations. As we mentioned earlier, fentanyl and synthetic opioids are the third wave of the opioid crisis. From 2013 to 2019, drug overdoses due to synthetic opioids, not including methadone, have increased by 1,000%, showing just how significant and far reaching the third wave of the opioid crisis is. So, now another subset of opioid derivatives that we should talk about is methadone, buprenorphine, Suboxone, and naltrexone. These synthetic opioids are used as both pain reliever options as well as treatment for addiction. So, in our first community conversation, we talked with Aaron Glenn, the Senior Director of Nursing at Carilion Rockbridge Community Hospital, and he talked about medication assisted treatment, which is basically using medication to treat substance abuse disorders. These medications are approved by the FDA, and the doses that patients received are monitored and tailored for those individuals. So, methadone basically changes the way that the brain responds to pain. It's an opioid agonist, which means that it blocks up the opioid receptors. This means that it reduces the cravings that people normally feel after taking opioids, and it blocks the effects if more opioids are taken. So, if somebody takes methadone and then takes prescription opioids or heroin, they're not going to feel that same euphoric feeling that they would normally feel, which helps to reduce the addictive cycle. Methadone is typically taken in liquid or powder form daily, and it can have some pretty serious side effects like restlessness, nausea and vomiting, difficulty breathing, chest pains, or fast heartbeats. And the doses of methadone have to be carefully calibrated for each individual person by a doctor. And buprenorphine is a partial agonist, which means that it has similar effects as methadone does, just not as strong. It helps to reduce the physical dependence on opioids by reducing some of the withdrawal symptoms that come from abstaining from opioids. So, Suboxone is another medication to be aware of. This combines buprenorphine and naloxone, which is a drug that can temporarily stop an opioid overdose by pushing the opioid molecules out of the receptor. Suboxone combines these two drugs to allow buprenorphine to be released to ease cravings and withdrawal symptoms in a way that does not allow for that euphoric rush. If somebody attempts to get that rush through the injection of Suboxone, the naloxone kicks out the opioids binding to the receptors, and they're not going to feel that high, which makes it extremely difficult to overdose. Naltrexone is actually not an opioid and is therefore not addictive at all. It blocks the euphoric and sedative symptoms of opioids by binding to those opioid receptors, which also helps to suppress the cravings for opioids. And because it's not an opioid, there is no addictive or abuse potential. However, patients who take naltrexone and then have a relapse to opioids will have a reduced tolerance to those opioids. And we talked about this in our past community conversations, but this means that their bodies have not been used to opioids for a while, so a lower amount can have a more significant impact, meaning that it's easier to overdose. And if we relate this back to the athlete metaphor, this is like taking a really long time off of running and then deciding to go for a 10-mile run at a really fast pace. My body's not going to be used to running, so that's not going to feel good at all. If somebody doesn't take opioids for a long time, their body learns how to function without it. If they have a relapse and have taken the same amount that they took before detoxing, they have a much higher risk of relapsing. So the opioid crisis is really important to be aware of, and it impacts a lot of people, but you can help prevent it from getting worse. RAPC has a lot of different resources that you can use to help prevent yourself and loved ones from becoming addicted to opioids. So there are medication drop boxes in 4 locations around the Lexington, Rockbridge, BV area. RAPC also has free disposable pouches where you can put your unused medication in along with water, and it'll deact the medication, so you can throw that pouch away. They also offer locking medication caps and timer caps that tell you the last time the medication was open, so you know if anybody else has taken it. They also offer 1 lockbox per family where you can lock your medication up safely. And then a little plug, there's a drug take back day on April 24th where you can drop off your drugs and they will dispose of them for you safely. Now, before we get to our Q&A session, we had some questions from our last community conversation, and we got some answers for you. People were interested in the naloxone usage in Rockbridge area. And what we found was that in the 2020 calendar year, emergency medical services used Narcan 7 different times, and the sheriff's office had used it 4 different times. And likely the BV data is also around a similar usage. But if you have any other questions after this community conversation is over, this is our last one, but feel free to put it in the survey that we'll send out after, and we can get those answers back to you as soon as we can. So now we're going to talk with Marcia and Molly. Marcia is a licensed professional counselor specializing in adult substance use disorder counseling. She earned a Bachelor of Arts in Psychology from Mary Baldwin College and a Master of Arts in Professional Counseling from Liberty University. Marcia began working in the field of mental health and substance use disorders in 2006 and working for several community service boards, including Valley CSB, Region 10 CSB, and now at Rockbridge Area CSB. She also owns her own part-time private counseling practice in Stanton. She earned her certified substance abuse counselor specialty in 2008 and provides a safe, non-judgmental space where she works with individuals suffering from substance abuse, shame, guilt, depression, anxiety, trauma, and those recently released from jails or prisons. In her free time, she enjoys spending time outdoors hunting, riding motorcycles, but most of all playing with her 2 grandchildren. Molly is a licensed professional counselor specializing in adult mental health counseling. She earned a Bachelor of Arts in Psychology from Mary Baldwin College and a Master of Science in Mental Health Counseling from Capella University. Her special interests include working with patients with substance use disorders, working with women who have experienced trauma, anxiety, depression, anger, and grief. And she is also certified in cognitive and behavioral therapy for insomnia, to diagnose and treat insomnia and other sleep disorders. Molly is passionate about providing a safe and non-judgmental space where she works with individuals to identify underlying patterns, which helps them to become better functioning and have a greater sense of well-being. She began working in 1995 with youths, adults, and families in diverse environments. Working with the Community Services Board and with public and private child welfare agencies, she provided foster care support services to children and their families. Molly is an active member of the Virginia Counselors Association during her free time, she enjoys spending time outdoors, running, and hiking. So I'll go ahead and stop sharing my screen. And then we'll get into the question and answer session. For Molly and Marcia, I'll ask some of you guys individual questions, but if you have at any point want to jump in and add on an answer, please feel free to do so. And thank you guys so much for being here.
Thank you.
All right. So let's get started. Could you both tell us a little bit about each of your positions and how it's brought you into contact with issues related to the opioid crisis? If you maybe want to start with Marcia and then go to Molly, just to get a little order.
Right.
Thank you. Yeah. Let's see. I've been working at Rockbridge Area Community Services Board for just a little over 3 years now. Provide mental health and substance abuse counseling there for mostly adults and a few teenagers as well. And of course, I do group and individual counseling. And several of my clients do suffer from opioid use disorders.
Thank you.
And I'm Molly Palavicini, and I've been working at the Rockbridge Area Health Center for a little over 3 years as well. I came in, my position was for a substance use disorders clinician because I've always had an interest in that. And so I started out seeing adults and children and began to specialize more with the substance use disorder clientele. And then about 1.5 years ago, we developed the Mountain View Recovery Program, which is an outpatient opioid treatment program. And so that's a program that offers Suboxone treatment along with psychosocial supports and counseling. And I'm the lead clinician in that program.
Awesome. Thank you. So Molly, could you talk a little bit about why the opioid crisis is something that we should be concerned about in the Rockbridge area?
Yes, well, I think that in general, it's something that we want to be concerned about in all of our communities because we want people functioning at their highest level. We knew that in this area that we had a lack of services. There wasn't a lot of access available to folks who were suffering with opioid use disorder. And we knew there was a crisis. We knew that there was increasing overdose deaths, increasing emergency room visits, folks that were involved in the criminal justice system due to the fact that they had an addiction. And we wanted to help. We wanted to mainly create access. And so we knew that by creating more opportunity for people to access the care they need, the more that we could foster a healthier community and that individuals could function at their highest level.
Thank you. Marcia, in our past community conversations, we've talked a lot about like the dangers of opioid addiction, but the recovery portion is also really important to cover. And we talked about methadone and buprenorphine as treatment options today. Could you speak a little bit more about what those treatments involve?
Yeah, sure. Kind of like what you were talking about a little earlier at the intro about what the Suboxone and methadone and stuff does in the brain. When it's taken prescribed, it is very safe and effective. It helps kind of diminish the effects of the physical dependency on opioids, such as withdrawal symptoms and cravings, and kind of increase safety in cases of overdose, and lowers that potential for misuse. Kind of to begin treatment, someone with an opioid use disorder patient must abstain abstinence from using those drugs. And to get into taking Suboxone, that person needs to be in the very early stages of opioid withdrawal. and then the doctor can do the induction after that. So when they come into treatment, that's one of the first things is they need to be in active addiction withdrawals. Here at RACS, we have that medication assistant treatment, not only just for the Suboxone, but we have outpatient groups and individual therapy as well, to kind of give a nice comprehensive treatment plan for that person. And then, for individual, if they also need to address any other co-occurring issues going on, like trauma, anxiety, depression. And then, of course, we encourage people to engage in a subculture of recovery, like 12-step communities or NAMI or Celebrate Recovery or any other recovery-oriented kind of self-help group.
Thank you. Going off that last question, Molly, would you be able to talk, this isn't one of the questions on the list that I sent you, but would you be able to talk a little bit about the Mountain View recovery and how patients can start getting involved in that?
Absolutely. So folks need to be 18 and over, and we do ask that they become a medical patient at the Rockbridge Area Health Center so that we can provide that holistic approach, and they would have a primary care provider here. The program is a holistic approach. So we have, providers called waivered providers that prescribe Suboxone, as well as naloxone that's prescribed along with that to help to prevent overdose. And we do have a segment of the program that we ask people to attend group counseling, and the group counseling is focused on psychoeducation, coping tools, skills to help people in recovery. And then we have an individual counseling component. But this is an OBOT program that was created under the umbrella of Medicaid when Medicaid expanded reimbursement for substance use disorders. And so individuals were in the past that weren't able to be provided with the service because they weren't able to afford it, can now afford the program through the Medicaid program that was developed and that we opted in. We wanted to be a part of that. So people can call our main number, the 464-8700, and ask to speak to the OBOT care coordinator. We also have some brochures. We're going to be supplying that to you, I believe, tomorrow.
Yes.
And be happy to walk folks through the process.
Thank you. And I guess you kind of already touched on this question a bit, but is there anything else that you'd like to share about kind of what the recovery process is like?
Sure. I always like to talk about recovery. I'm pretty passionate about it. We know that hope is really the catalyst of the recovery process. It's important for us to know that it is person-driven, that it is patient-centered, meaning that there are many different paths to recovery, and that we value that, and that we're helping people to become more self-determined and to define their own goals. I feel like our job is to kind of empower people and then provide resources. And as Marcia said, the recovery community and having support around you, whether it's family, friends, and as Marcia talked about earlier, many of the mutual support groups that are out there. We also feel that the concept of a peer support recovery person is important, and that's a person who has been in recovery themselves and has been hired by us, and I believe also the CSB has a peer support recovery individual, because sometimes, they've been there, done it, and sometimes they can identify with patients, and patients are more willing to speak with them even than with a counselor. And so the peer support is also a core part of recovery.
Thank you. Marcia, would you be able to share about some of the barriers that might be there in accessing and maintaining treatment?
Yeah. First and foremost is that own individual's self-perceived, their shame and their guilt. That's probably one of the bigger hurdles or barriers to treatment is themselves. And so that's a big hurdle for that person to overcome. And transportation seems to be a big issue, especially in a rural area. There's not a lot of public transportation. People don't have driver's licenses or vehicles or someone to drive them to and from all their meetings and appointments. And especially now during COVID, doing telehealth services has been a little bit of a barrier for people here in a very rural area like Rockbridge, because not everybody has access to Wi-Fi or being able to get online and do Zoom or Microsoft Teams meetings. So that's been a big barrier, also. So.
Thank you. Yeah, those are good points. Molly, could you talk about some of the factors that help someone to be successful in recovering from opioid addiction?
Sure. And I think, some of it we've already talked a bit about, and I'm happy to elaborate, more. I think having, the support in your life, whether it's through family or community support, is very important for folks. For people to feel that they're not being judged, because what we do know is that stigma is still very real with substance use disorders. And also the understanding that relapse really is part of recovery. And when we say that, we mean that. And so people are hardest on themselves and often feel that if they relapse with one substance or another substance, that they have failed. And I think it's really incumbent on us as we support people and teach people that is part of recovery. We help them to identify kind of what went wrong, and we use the relapse as a tool for people to say, what did you learn from that? Because there's so many learning opportunities that can happen. But to keep people engaged and to say, okay, let's get back on the horse. Let's see what we can add. Or what do you think, we could, how you could do that better the next time, to help them to begin to have more self-acceptance and understand that this is a journey. Addiction is a disease, and it's chronic and it's relapsing. But that you want to keep at this and not give up, and have folks around you that feel in a similar way. We talk about more specifics, like, if you're living with someone that's using, it's going to be harder. I'm not saying it's impossible. It's going to be harder for you. And so that's where you want to try to fill people up and kind of put a foundation around them. So because the journey can sometimes be challenging. I always tell folks that, sometimes you think, well, you're in recovery, that's wonderful, wow, it's great. No, after you're sober, things get different. They don't necessarily get better right away. They will get better, but they have to be realistic, and we're there to be with them in that journey.
Thank you. And going off of that, and how important support is during the recovery process, Marcia, could you talk a little bit about how friends and family can be helpful in the recovery process? And maybe are there some things that they might do that aren't that helpful, even when coming from a place of love, and how to handle that?
Absolutely. Yeah. First and foremost, it would be best to stop enabling that person, the addicted person. And it would be good if the loved one of the person in recovery also get their own counseling, or look into some self-help groups, or like Al-Anon and NAMI. There's others out there as well, but getting their own support as well would be really helpful. Good communication, asking questions and being honest, and being patient with their loved one, but also themselves. But I really think communication is a really big key in all relationships. So asking questions and learning more about the disease and figuring things out together, you know, to kind of each other support one another through that journey.
Thank you.
Mhm.
And then another question, Marsha, I think you talked about this a little bit earlier, but COVID has been a huge part of everyone's lives and has caused a lot of changes, especially in the workplace. So how has the pandemic impacted the way that you guys provide care to your patients?
Well, it changed it a great bit. We went from doing group substance abuse treatment to, for a good long time, we were doing individual one-on-one sessions with people by telephone or telehealth services using, you know, a platform like this. And gradually we started also then incorporating some groups. We were able to kind of use this type of platform like the Zoom or Microsoft Teams to incorporate and doing some groups. But there's some communication issues that go with that, you know, keeping people on mute. And then next thing you know, somebody's trying to talk and we're like, we're on mute. So that's been kind of challenging. And at first we didn't have a way originally to start doing urine drug screens, which is a part of the treatment. It's a bit of accountability there. So then eventually we were able to do some in-person at racks to do urine drug screens, and then we were also using a local lab to help get us some of those urine drug screen results. So yeah, it kind of it was kind of evolving as the year went by, but I think we're doing much better at that now. So, and then we'll be going back to some in-person kind of slowly now. So,
thank you.
Mm-hmm.
Molly, have you noticed the same thing in your area?
Yeah, actually, very, very similar to what Marsha said. We did some similar things here as well. We have our weekly group that we, for a period of time, had to stop. Had to figure out all these platforms, telehealth, things that we hadn't really thought about. But now has become very useful tools. So we went from doing some just individual sessions to now we have restarted our group that's been going now a month, and it's a telehealth group. So it's very similar to what you're doing. And so challenging the clinicians about technology and helping patients to understand that it's still safe and can be confidential and is confidential, and informing them about that process, again, the risks and benefits. I do want to add that I'd forgotten this, that one of the really nice components of our program is that we do have a care coordinator. I mentioned that person earlier, and what was the most helpful during the pandemic that we noticed is that person continued to stay in touch every week with each patient. So if they weren't able to attend a group, didn't have Wi-Fi, for example, or some other barrier, she was still that constant that reached out, and talked to them, making sure that they were doing okay, just kind of a check-in. Do you need me to set up another appointment with your counselor? Or how's it going with that job search kind of thing? And so we really utilized her role so that people felt like they were still a part of, because we still prescribed the medication. It was just the psychosocial supports that we weren't able to offer in the same way.
Yeah, thank you. And then one last question for both of you. Could you talk a little bit about what life after recovery from addiction looks like? Maybe Molly, want to start off and then go to Marsha?
Yeah, so life after recovery, it's something that we do sit and talk with people about. Gosh, we want people to be doing what they want to be doing. So helping them to get a job back, if that's what they're interested in working again. Oftentimes folks have lost their driver's license. And they may have fines, or they may have other barriers, but trying to help them to identify goals that are doable, right? Some aren't, but many of their goals are doable, and helping them to access ways to achieve those goals. Our care coordinator works with people, again, to help them to get their driver's licenses back if possible, and going through the whole process of contacting DMV and all of those things that can be challenging. Oftentimes we know relationships are strained and actually harmed a great deal. People get to see their kids again. Parents maybe get to have their children back in their own custody. Or if nothing else, just repairing relationships. Their health improves, right? I mean, we forget about that sometimes, but people begin to feel better, and then they want to give back to their community. Now, having said all that, um, it still has its own set of challenges because you're getting to know yourself again. You have feelings that you suppressed for all these years and numbed, and what do you do with those feelings? And so it's a lot of remediation and teaching skills to people so they can live their best life. It's about their best life.
Thank you.
Yeah, and I kind of think that Molly really just summed that up really, really well. And the only thing I can think of to add to all of that is just that person's own self-confidence and self-esteem, building in that person as they go through their recovery journey, because as we know, recovery just is a lifelong process. Once you've been done and you've finished with treatment, now suddenly I'm cured. No, this is like any other, chronic disease. It is lifelong, and it has to be managed. So, keeping not becoming so complacent with their recovery, and staying with their goals, like Molly was saying. So
Absolutely.
yeah.
Thank you guys both so much for being here today. Your perspectives were great to hear. Great information. Thank you so much. And thank you to everybody who came to listen today.